Our next lecturer is Rachel Katz. She is Director of Integrated Substance Use Services and lead nurse at the Community Health Centers of Franklin County.
Hi, my name is Rachel Katz. I'm a family nurse practitioner and the Director of Integrated Substance Use Services at the Community Health Center of Franklin County. I'm going to be talking tonight about establishing a substance use disorder treatment program in your practice. So to start off, I think that sometimes primary care providers and outpatient providers think that treating addiction in a primary care setting is just too complicated to be done well. It's also big and scary. And tonight I'd like to start breaking down some of those barriers and show you all that it really is rewarding and easier, I think, than titrating insulin or starting an anticoagulant, which are things that we do in outpatient practice all the time. So as you all know, the statistics around opioid use disorder and overdose are really staggering. The one thing that I would really like to highlight on this slide is that nearly 80% of people with an opioid use disorder report that they don't receive any treatment. And that can be for a variety of reasons: difficulty accessing care or the stigma surrounding substance use disorder. But really getting more substance use disorder treatment into a primary care outpatient setting can really help reduce that number. So I want to go through some of the myths and realities about treating opioid use disorder, because I think the myths are really prevalent and the realities are not as often talked about. So buprenorphine treatment is more dangerous than other chronic disease management is one of the biggest myths I hear. Prescribing buprenorphine sounds big and scary and dangerous. And really, buprenorphine, I think, is one of the safest meds that I prescribe. And it's actually really easy and simple to titrate and dose adjust. I would certainly rather prescribe buprenorphine than titrate a complicated insulin regimen. The difference is that many primary care providers and physicians don't receive a lot of training in addiction or the medications to treat addiction. So it is often just this thing that is big and scary, and people don't feel confident in doing it. The other myth that I often hear is that use of buprenorphine is simply a replacement addiction, that you're just giving one opioid for another. But if we're thinking about addiction as a chronic disease, then buprenorphine is the medication that we're giving to treat that chronic disease. So much like you give insulin to treat diabetes, we give buprenorphine to treat opioid use disorder or addiction. Detox for opioid use disorder is effective, and there's really no data that actually shows that. Recurrent detox actually can increase the risk of overdose, because as people go through detox and they get the drugs out of their system, then their tolerance goes down and then they can overdose if they go back to their old use. Prescribing buprenorphine is time consuming and burdensome. So again, I actually find prescribing buprenorphine is much less time consuming than talking to a patient about warfarin or about titrating insulin. You don't need a lot of in-depth counseling or group work in order for buprenorphine to be a successful treatment and in order for folks to get better while they're being treated in an outpatient setting. And then often I hear, well, we're not prescribing as many opioids for chronic pain. Like, obviously things are just going to get better on their own. And unfortunately, despite the decrease in opioid prescribing, the overdose mortality has increased. And one of the thoughts surrounding that is that as folks are losing their opioids that they've been getting for chronic pain or that are being prescribed to them, they're actually shifting to the illegal or the illicit drug market, where the risk of overdose is higher because they may not know what they're getting, they may not know how much they're using, and so more folks are likely to overdose. So the office-based addiction treatment model is often called the OBAT model, and it was first established through the Boston Medical Center and is now known as the Massachusetts model. So it is a model in which addiction-trained and ex-waivered providers, so both physicians, NPs, physician's assistants, are able to treat multiple substance use disorders in a primary care or outpatient setting with the help of nurse care managers. And it uniquely uses medication for addiction treatment. So there are many other programs that specifically use counseling or group work or an abstinence-based program, and the OBAT program is not necessarily that kind of model. So the philosophy of OBAT is that a substance use disorder is a chronic, remitting, and relapsing medical condition that responds best when treated with evidence-based and patient-centered comprehensive medical care. So moving it into the medical model, moving addiction out of the psychological or the psychiatric model and really bringing it more into a medical primary care model. So the goals of OBAT are patient-centered and patient-driven. And so while one of the goals is the cessation or reduction in harmful substance use, really I think about OBAT as helping patients achieve their best life. And their best life is how they choose to define their best life. And so if they're looking simply to reduce their substance use or their drug use, and that enables them to more fully participate in their family or more fully achieve their life role or their goals, then great, then we consider that a success. We want to improve someone's quality of life. We don't want them getting sick with drug cravings or with withdrawal symptoms. And while some folks may move completely towards sobriety and complete abstinence of drugs or alcohol, that doesn't necessarily have to be their one and only goal in order to participate in an OBAT model of care. So I currently practice at the Community Health Center of Franklin County, which is located in Greenfield, Massachusetts. Greenfield is the county seat of Franklin County, which is one of the largest by square miles, as well as one of the poorest counties in the Commonwealth of Massachusetts. So we're a federally qualified health center that was founded in 1997. We're essentially a family practice. We serve patients from infants all the way to elders, and we fully integrate our medical and dental services and have a variety of outreach programs. So the OBAT program at the Community Health Center started in 2016 when the leadership and the providers realized that there needed to be more integration of care between primary care and then also for their patients that were being treated for substance use disorders. So a lot of research was done, and it was decided to apply for a grant from SAMHSA, which we applied to in 2016. We were awarded in 2017, and then our full program rolled out in January of 2018. So primarily what this grant allowed us to do is hire an OBAT nurse care manager who specifically went through OBAT teachings and trainings, and then was able to really roll out the program to the rest of the providers in the health center. And this was also the beginning of our jail transitions program, which I'll speak a little bit more about. So quickly, we started to do some SBIRT screening, which you may or may not be familiar with. So we now give everyone an SBIRT screen on either the medical side or the dental side, and they get one at least once a year. So this allows us to really fully identify patients who are having harmful or irregular, chaotic drug or alcohol use, and hopefully integrate them more into care and into our OBAT model. So just a quick word about screening. We essentially function as a low barrier and an easy access clinic, and we support a low threshold for medication trial. But just because someone is willing to start medication or start their treatment within an outpatient or primary care setting, it doesn't necessarily mean they're going to be successful there. So screening is important, and I encourage everyone to use it, but it doesn't tell us which patients are going to succeed within an OBAT model. So stakeholders and key clinical players, obviously before you start this kind of program, it's really important to get everyone at the table and get buy-in. So in our case, that was the board of directors and our leadership team. It was the medical providers, it was our nurses, and then specifically this nurse care manager that we hired, medical assistants, and then our integrated behavioral health team, but also reception. And I feel like reception is often something that is overlooked. So reception and front desk staff, reception and front desk staff are the first line for our patients. So they are the folks that they interact with the most frequently. They answer phone calls, they make appointments. And so if your reception staff or your front desk staff is not on board and they don't have buy-in for why this is important work, then you may come up with a fairly significant barrier. So moving into some sort of administrative nuts and bolts of how to get a program started. So I really encourage the establishment of a core treatment team, one provider, one nurse, one medical assistant, one receptionist if possible. This is really trauma-informed care. It allows our patients to be interacting with the same team over and over again, which is building trust and rapport with the patient. I also really encourage everyone to adopt a standard treatment protocol and roll it out across the board. All providers, all nurses should really be doing the same thing all the time. It sets expectations for patients, providers, the office. Otherwise, you can get some ad hoc patient-specific medical care, which is just not great care. Clinical expectations, again, for both providers and patients. So Things like what happens if a patient is asking for an early refill? What happens if they are running out of their medication? What happens if someone has an unexpected toxicology result? What are the clinical expectations there? What are you asking patients to do? And also then what are you asking providers to do in order to provide the best care? Also, appointment scheduling and the no-show policy. So folks with active drug use who are in active use often have chaotic lives, that things are very hard to pin down or nail down. So I really encourage everyone to be flexible with their scheduling, to have open slots in their schedule, to work with reception and the front desk to try and get people into their schedule. But then also have a policy about no-shows, whether or not you're going to accept patients who are late, what you're going to require for rebooking. Sort of a tricky little thing is tracking providers' X waiver limits. So every time you apply for an X waiver or the license to prescribe buprenorphine, you're going to have a patient limit. And so over periods of time, you will then be able to increase your patient limit. So who in your practice is going to be tracking that? Who's going to be asking for those increases? Who's going to be monitoring how many patients you are prescribing for? Documentation in the EMR can be crazy, and we all have different EMRs. So whatever your EMR is, I encourage setting a template or a quick picks, fast text, whatever it is, and just making sure that it's in there and that everyone is using it. Again, we want to make sure that documentation is standardized and that all of the important information is getting in there. So some clinical nuts and bolts. Toxicology testing. So I will talk a little bit more about toxicology testing on the next slide, but think about how you're going to be doing toxicology testing. So whether it's a urine drug screen or the buccal swab, the oral swab, how you're going to handle unexpected results, how you want to work that into practice. Really monitoring for polypharmacy. So not only polypharmacy regarding other medications that your patients are getting from other providers, but then also any other illicit drugs that they may be using. So really checking in with emergency rooms, psychiatrists, therapists, other outpatient providers, making sure that you're checking the prescription monitoring program, or MASPAT as it's called here in Massachusetts, monitoring for other prescriptions that may interact with buprenorphine or active substance use. I encourage prescribing comfort meds for everyone that you're going to prescribe buprenorphine for. Comfort meds are used for alleviation of withdrawal symptoms. So if you are worried that someone is in active use or will have some precipitated withdrawal, and I would encourage comfort meds. So my comfort med cocktail is always ibuprofen, 800 milligrams every 8 hours as needed for body aches, Zofran, 8 milligrams every 8 hours as needed for nausea and vomiting, and then clonidine, 0.1 milligrams 3 times a day as needed for anxiety or elevated blood pressure. The most important clinical nuts and bolts, in my opinion, is Narcan. So everyone who walks into my office and gets a buprenorphine script also gets a Narcan script. In Massachusetts, there's a standing order at every pharmacy that you can walk in and get a prescription for Narcan. I also always make sure that I prescribe Narcan, and I prescribe enough, not only for my patient, but for their friends, for their family, for anyone who is around them. Our patients cannot get better if they are not alive, and Narcan is what keeps our patients alive. And then infectious disease screening and pre-exposure prophylaxis for HIV. So I screen all of my patients when they first come into care for HIV, Hep C, syphilis, and all of the other infectious diseases, including Hep A and Hep B. And then I also routinely screen them throughout their care, especially if they are continuing to engage in risky sexual practices or injection practices. And then the pre-exposure prophylaxis for HIV, I really encourage you to be using it, again, especially for patients who have riskier sexual behavior, risky injection practices, are possibly exchanging sex for drugs. If you are not comfortable with pre-exposure prophylaxis, it's actually really simple. And so I encourage you to look it up, to get comfortable with it, to start prescribing it for patients. So just a quick word about toxicology testing. It is meant to be a tool in the toolbox. In no way, shape, or form do I endorse using toxicology testing as the one and only method in which you are assessing your patient's adherence or compliance or whether or not they're getting better. It is meant to help with patient safety. It can help prevent the diversion of medication. We have many patients that come back and report that urine drug screens especially are invasive, they are dehumanizing, they're stigmatizing. People don't want to come in and get their prescriptions. They don't want to come see the doctor. They know they're going to have to pee in a cup. And so, I encourage you to think carefully and closely about how you're going to be using toxicology testing. And then certainly if you are going to be running tox screens, to really use the buccal swab, the oral swab, instead of the urine test specifically. So some common pitfalls: getting providers X-waivered. It does involve some extra training, which can take some time. It can take a while for the DEA to get back to you with your X waiver. So just making sure that you're giving yourself enough lead time to get that set up. Time for trainings. We work in busy outpatient practices. Time is our most valuable essence. So allowing yourself to have some time set aside for trainings, and then to be able to continue those trainings as you move further into practice. Coordination of care, always hard, especially tricky with the 42 CFR rules and regulations, which specifically safeguard information about addiction treatment and care. So making sure that you're getting signed information, consents, releases of information. Again, I try and make sure that I always have them with a therapist, with a psychiatrist. If anyone is getting specialty treatment for Hep C or for HIV, making sure that we're all collaborating and communicating. So some common or some special populations. So folks who are biracial, Indigenous, or people of color, I think it's really important to have an overall frame for treating this particular population. So the war on drugs was racist and is racist and continues to be racist. And so folks of color are not only marginalized because of systemic racism and all that that implies and the effects that that has on their health and chronic diseases, but then also with addiction is sort of a double-edged sword. And so just being really mindful that these are folks who are more likely to develop complications from substance use disorder, are less likely to receive care for substance use disorder, are certainly less likely to be prescribed buprenorphine for opioid use disorder, and just really making sure that we have that overall anti-racist lens to the work that we're doing. People who are legally involved or incarcerated is another pretty special population. We definitely worry about the transition from incarceration to an outpatient setting. So for folks who have been sober in jail and then come out of jail and go right back to their former drug use, the risk of overdose is really, really high because their tolerance while they're in jail has gone way down. They come back out, they maybe go right back to using the same amount of drugs they were using, or the drugs that are now on the market are different than the drugs they used to use. And so super important to make sure that we are actively reaching out to people as they're leaving incarceration and that we're getting them into treatment. And again, folks who are transgender or non-binary, a really marginalized population, lots of medical trauma specifically. So being really mindful and trauma informed in our care. So advice I wish I had gotten, I would say that it would start and end with harm reduction. So I came into the world of harm reduction a little bit later. I started treating addiction before I really got educated on harm reduction. And so I think if nothing else, you want to start and end with harm reduction. Our goal is to help our patients be healthy and to live their best life. And so talking about safer injecting practices, who they're using drugs with, are they being sexually exploited? And if nothing else, if I can help people use drugs more safely, then for me, that is the goal. If I can help people achieve their goal of sobriety, then great, I'm happy to do that. But ultimately, I want to keep people alive and I want to keep people healthy and I want to collaborate with them on that goal. Other advice I wish I had gotten is there are specialists. You do not have to do this alone. You don't have to reinvent the wheel. Ask for help often. There are people out there that can help you and can help ease this journey for you. And then setting some self-care and some boundaries. And really what I mean by that is making sure that your own internal sort of heart and soul are being taken care of. taking care of folks with addiction is brutal, and addiction is the worst disease I have ever treated. And you will likely lose patients, and you will likely lose patients who are young and die really tragically. And so I encourage everyone to think about how they want to hold that and how they're going to take care of themselves through that process. So some resources, the one that I really just want to highlight is the Boston Medical Center OBAT Technical and Training Assistance website. So if you really want to get into this kind of treatment and you're looking for protocols and algorithms and ways that you can really start this kind of program, then that's absolutely the website that I would go to. The other ones you can certainly take a look at, and I'm happy to answer questions. So finally, it isn't easy, but it's worth it. As I said before, addiction is the worst disease I've ever treated. It steals people, it steals families, it steals children, but it is also one of the most rewarding things I've ever done in my 13 years as a medical professional. I had a patient just earlier this week who I've treated for many years, and honestly, I wasn't sure that he would make it. His drug use was really dangerous. It was really chaotic. And he's now been 2 years sober from opioids, 6 months sober from alcohol. He's holding down a full-time job, and he is just who he was meant to be. And he's so proud of himself. And to be able to walk with him on that journey is immeasurable. So I encourage you to take this on, to think about it. It isn't easy, but it is 100% worth it. Thank you.
Key points from Rachel's lecture. Patients with substance use disorder already exist in your clinical practice. There are many models to begin treating patients with substance use disorder in your practice. It is okay not to know all the answers. There is help and advice, locally and throughout the state, to help you to integrate treatments into your practice.